welcome everyone to the Oregon-Nevada Chapter Fall Virtual Conference. We hope your families are healthy and staying safe. A couple housekeeping items. We want to remind everybody that towards the end of the session, we'll put in the chat box a survey. We would love it if you would take the survey. It allows us to continue to provide you the education that you want. Also, the following day, there will be another survey going out of the general conference. So it'd be great if you could fill that as well. Our next virtual conference is going to be in January 2021. And we hope to have our first in-person conference in May at Salishan. So fingers crossed that we'll be able to do an in-person conference. A special thank you to all of our volunteers for helping us put on the conference. It takes a lot of time and effort, so thank you very much. If anyone is interested in volunteering, please feel free to reach out in the chat box. We would love to have you help us out. Our keynote speaker for this session is KeyBank. KeyBank is one of the nation's largest bank-based financial service companies, making it easy for you to bank anywhere. They're committed to helping their clients and communities thrive, and to that means doing business fairly, responsibly, promoting diversity and inclusion, and making meaningful investments in places where people live and work. Thank you, KeyBank, for your ongoing support of the Oregon chapter. We appreciate it. This session is Healthcare Updates by Andy Easton and Rebecca Teal. A little bit about them is Andy Easton has a long tenure in healthcare issues and policies. She currently serves as Vice President of the Government Affairs of the Oregon Association of Hospitals and Health Systems. In this position, she manages lobbying teams of OAHHS and engages members in grassroots activities in Salem and Washington, D.C. After growing up in Idaho, Andy graduated from the Oregon State University with a degree in healthcare administration. She and her husband are raising their daughter, who has a birthday coming up. And her daughter is already showing strong independent leadership styles. In 2010, Andy was the recipient of the Portland Business Journal's 40 Under 40. In 2019, the Portland Business Journal recognized her as an influencer in the legislation. Rebecca is the Director of Public Policy of the Oregon Association of Hospitals and Health Systems. She's responsible for management of member-driven public policy development and related to the state and national health policy, including delivery system transformation, addressing affordability and value, hospital community benefit, and public health policy. Rebecca currently serves as chair of the state's Public Health Advisory Board. Prior to her role, Rebecca worked as a health promotion of chronic disease prevention policy specialist in the Oregon Public Health Division. Welcome, Andy and Rebecca. We're happy that you could join us today.
Great, thank you. I am going to go ahead and share my screen. Well, good morning, everyone. Thank you again for inviting Rebecca and myself to join you on your virtual webinar. Today, we're going to give you an update of what's happening in the political arena, and some of the policy updates that we will share are ones that we have talked about in the past with many of you, and many of you have participated in the kind of the fine edging of rulemaking with us, but we want to make sure everyone has an update on those as well. As you can see, Rebecca and I are both still working remotely, and so we welcome you into our homes this morning. Please enjoy yourself, grab a cup of coffee, tea, water as we go along. We hope to have a very engaging conversation with you. So our goal is to kind of lay the political land of what we anticipate happening in the next legislative session as a result of what an unprecedented year this has been. And that will include talking a little bit about the elections and how the legislature will operate in the upcoming session. And then I'm going to turn it over to Rebecca, who's going to talk about the implementations of Senate Bill 889, the healthcare growth target, as well as House Bill 3076, the community benefits. So framing this year, this has really been an unprecedented year set by four very significant events that have influenced all of us from the national level to the state to a community and then to a personal level. This includes an unfinished 2020 legislative session due to a Republican walkout over political infighting, a COVID-19 pandemic that occurred less than 2 weeks after the session ended, and then a nationwide, which also sparked a lot of protest here in Portland as a result of the killing of George Floyd. And then in August, September, we had some really devastating statewide wildfires that caused significant harm and destruction to many of our communities. So, example of how these four major significant events are influencing the Oregon way, or what I like to say, how Oregon is like a pioneer in many different aspects, is that in the wildfire case, a lot of the traditional platforms that we've seen on the national level with politics and infighting there has been done via tweet. And we actually saw some of that transpire here more at a local level between the governor and Republicans over the wildfires. And there was some misunderstanding, and it is also an election year, so we have to take that into consideration too. But the governor essentially blamed or sent the sense out there that she was blaming the Republicans for the wildfires. This is not normal Oregon traditional politics. This is a very new way of doing politics in Oregon. And so we're beginning to question whether or not the Oregon way is changing to more reflect of the national level. We've also seen in the last 18 months that the Senate Republicans have walked out 3 times. They did so in the 2019 session on 2 times with vaccines and guns, and climate was their first walkout. The second walkout was on climate. And then the House Republicans joined them on the 3rd time they walked out in the 2020 session, which closed that 2020 session early because of the climate bill that was out. So we had those walkouts, one of which completed and closed down the 2020 session. And we've had 2 special sessions since then. The 2 special sessions, the first one was in really a response to the public outcry that we have seen with the continued systemic racism and the killing of George Floyd, and the need to have some police reform. But it also was an opportunity for the state to look at some potential response to COVID-19 and if there were any significant rules that needed to be addressed to respond to that. The second special session really was focused more on how do we address the budget, because we weren't able to rebalance the budget in the 2020 session. We had to find a way to really adjust that budget and close the $1.2 billion budget gap that had occurred as a result of COVID-19. That special session adjourned in August. Weeks later, wildfires started up. The governor then sent a note out to leadership without negotiating with leadership in advance that she was going to line item veto some of the budget pieces that were passed in that second special session. By doing so, she triggered an internal fight between the leadership, Senate President and the Speaker of the House, for not giving them enough heads up, have noticed that this was the action that she was going to do. So that line item veto really has sparked some internal disagreements and struggles, I think, between the presiding officers. And we are anticipating a 3rd special session, likely after the elections, but before Thanksgiving, to address any additional budget needs that need to come out. for wildfires or for COVID as we go into the flu season, but also perhaps looking at some housing and other housing issues and other regulatory issues that need to be addressed because of the wildfires. The impacts that COVID has had on the state so far really have been around public health measures, government oversight, in really setting some unprecedented ways. The flexibility that the governor has as being governor in a state of emergency when it's been declared, she can make some executive orders, in which she did, including one that restricted some non-urgent procedures by hospitals and other ambulatory surgical centers. She limited the commerce of the state, so limited how and where and how many folks could gather in social gatherings. Recently, we did a statewide face covering requirement that has been more enforced, more emphasized, I guess, in the recent weeks. And then we've seen a lot of moving to online and remote work. I know our association in the Clackamas County area, we are still closed, and we anticipate that we will be working remotely until the beginning of the year. Schools, majority of our schools are also working remotely, and that has had some significant impacts on our workforce. So the other issue here that we want to highlight is the continued inconsistent national strategy and alignment as we try to move forward in containing COVID-19 and knowing that going into the flu season. So the impacts that COVID has had on the legislature itself, it really has limited our ability to engage with legislators, as well as to have access to the public Capitol building. The building itself is closed. It's open to legislators on a limited basis, as well as some select staff. But when we go into special sessions, e-board, it really is limited to how we can engage. And so we've been doing most of our work via remotely, such as using Zoom platform. Teams platform is another one that the state has been using. And by doing this, it really restricts kind of that public input that really makes Oregon government as strong as it is. And it also creates some frustration with the lack of process and transparency by those who want to be more engaged. And so what we're beginning to see is that because the lack of transparency and inclusion is happening, the minority leader in both the House and the Senate feels like they are being excluded from some of the significant conversations that are happening. And then the rank and file, both of the majority and the minority in the House and the Senate, really aren't sure what's going on. They're also not being convened to be told, okay, here is what we're going to do. And so there's a lot of frustration that they don't have the opportunity to represent their constituents to the full capacity that they would like to. We've also seen an elevated role in the emergency board, often referred to the e-board. The emergency board is a constitutional group that meets of legislators. It's bipartisan, bicameral. They meet during the interim, so in between our sessions, to really maintain a check and balances on the budget, to make sure the budget stays afloat. And if there needs to be appropriated additional funds to certain areas for projects, et cetera, they have the authority to do that. What we've seen in the last 8 months is that e-board has also become a place of where some policy has been made and then pushed out through additional funding requirements. So they've taken a different role on, and they are saying, leadership is saying that this e-board should be used this way. I think others in the minority are saying, no, it shouldn't be used that way. It should be, if you're going to do policy changes of substance, that needs to happen through a special session where all legislators can weigh in. So we know this is an election year. We have to talk about it a little bit. We'll try not to get into too much of the political weeds and one side over the other on this. I come from a very political house where my husband and I both are involved in politics. So we respect and we understand the sensitivity of this issue, but we do think it's important to kind of lay out what we are seeing as it will impact or could impact the work that all of us do. So it's really a tale of kind of two elections, one a federal and then one a state. If we look at the presidential election, which is at the top of our ticket, top of our ballots, we know that the president's approval ratings prior to COVID were, fairly good. They were near and hovering over 50%, which is not a bad place for a president to be going into an election. Of course, personally, they would always like to be higher, but 50% is not a bad spot to start in. COVID hit. We saw the campaign begin to shift. The dynamics of COVID, the lack of a strong public health message, and frankly, the lack of, I think, him following the message that he was sending out, combined with the social unrest of the killing of George Floyd, really started to unravel his favorability and his approval ratings. And what we are seeing now is that the president is hovering very in the low 40s of his approval, which has allowed for the Democrats, the Biden-Harris ticket, to really kind of ramp up. And polling suggests nationally that Biden leads substantially by double digits in many of the states, if not nationally at a whole. And at the battlegrounds that we'll talk about here in a little bit, he is gaining some extra support. He's focusing in on suburban women, seniors, but just general turnout and making sure that people get the vote out, feel like they can mail in their ballots without feeling that they are being hurt. And then the president is not doing that. He has a different approach that he has taken on. And so we'll see. We are in the final 2 weeks, less than 2 weeks of the election. A lot can happen between now and then. Our votes that you and I all make are part of the populist vote. We also have the electoral college vote. And the electoral college is a longstanding, it's based in our Constitution. It's a temporary group of electorates who are chosen to represent a state for voting purposes. Each state is allocated the same equivalent number of what they are represented in DC. So Oregon is represented by 5 members of the House and 2 senators. So we have 7 electoral votes. They will vote, usually representing the state as a whole in their vote. The total of electoral college voters is 538. You need 270 to become president. So what we will see and what we could see, the current Cook's latest scenario, which is a fairly relied upon group, they show Biden up, 20% or 20 points higher than what is needed. And so that's kind of where we're going into this election. Anything can still happen. It is likely, it is possible, anything is possible between now and November 3rd, that things change. Another October surprise happens. Some of the toss-up states, if not all the toss-up states, go Trump, and maybe 1 or 2, 3 of the leaning Democrat states move over to support Trump, and he has enough to take that presidency again. So a lot can still happen in these last remaining weeks, but what we are seeing is a huge increase of early voting. States that have already sent out their ballots, people are voting and they're returning those votes earlier than we have seen in historical races. So if we look at Congress, House of Representatives, we do not anticipate there being any significant change in the House of Representatives. Democrats will likely remain that control. They may pick up a few, they may lose a few, but in general, they should stay around that 230, 234 seats. On the Senate, and the Senate is really the chamber to watch right now. There are more seats up for grabs, per se, that are in a battling grounds that both Republicans and Democrats are either going to try to protect or try to gain. So we could easily see at the end of the day on November 3rd or 4th that there is a split or a 50-50 Senate, and or it could be a 54 Republican lead, or it could be a 51 Democrat lead. I mean, there's still a lot of numbers in play and a lot of unpredictability in many of those states. So the elections are going to be important for a couple of reasons. Right now, the Senate Judiciary Committee, and I think in just a few hours, will be putting forth the recommendation of Amy Coney Barrett for the Supreme Court. They will make that vote likely today, and then it will go to the full Senate for further confirmation. We have heard, and pretty publicly, that the Senate Ds are likely not to show up and provide quorum for that final vote, therefore suspending the nomination of Judge Barrett till after the elections. Depending on what happens, the Supreme Court does not need that seat filled to continue with its decision making. So what we should anticipate happening in the next couple of weeks or months is the court meeting and discussing the future of the Accountability Act. We know that under President Trump, he continues to pick away at what the Accountability Act does. And so those elements of it are still in the hands of the Supreme Court at this time. If the Democrats run the table, meaning they have the majority in the House, the Senate, and in the White House, we will likely see some really strong efforts to restore the Trump Accountability Act cuts and expand coverage. There will also be a debate over Medicare for all. And then we'll see a shift in the decisions on how do we address our deficit and what does that reduction look like. So we will have those conversations should the Democrats take control. If the Republican Party keeps the White House and the Senate, we will have further repeal and replace of the ACA and other potential initiatives. And then we will have major deficit reduction effort with the focus being changes and cuts to the Medicare and Medicaid plans. So what do the elections look like here in Oregon? Bringing it closer to home, the House currently has a supermajority, so does the Senate, where the Democrats lead 38-22. And the Senate is 18 Democrats to 12 Republicans there. So the supermajority allows for the House or the Senate to take votes on taxes without the need of a member of the other side of the aisle to support it. What it doesn't give the parties and where they would like to go is quorum-proof majorities. So in the House and in the Senate, they have to have 2/3 of the chamber to be present to start a quorum, and that is to engage in doing business of the various chambers. So the House Democrats are looking at picking up 2 seats, and same with the Senate Democrats to get that quorum proof, which would prevent walkouts by the minority party to stop legislation. The Republicans on the other side of the coin are really kind of fighting to restore balance. They are using messages that politics is local. Look and see what has happened under the leadership of Democrats. They've increased your taxes. Let's try to bring it back home and restore some type of balance. And for them, a win of 1, 2, or 3 seats would be a significant win for them. The Democrats' message is really focusing more at the national impact and how can they tie their Republican opponents to President Trump. All of the House seats are up, and about half plus 1 of the Senate seats are up for election. Senate seats are every 4 years, House is every 2 years. So we have 76 legislative races in state going on. Plus, if you look at the top of our ballot, we have Secretary of State also in a race too. So the competitive races are pretty limited. There's really a really strong focus on what are those battleground districts. And those currently, and this is true for both House and Senate, it's Salem, Bend, Central, and North Coast are the ones that both the Republicans and the Democrats are focused in on in either keeping those seats, such as in Bend, House Republican Representative Helt is in a very strong position to try to retain her seat, but she's out. If you look at the registration numbers for Democrats supersedes that of Republicans. So she is really trying her hardest to maintain that seat, whereas the Democrats in that position really want that seat. It's important for Republicans to hold that seat because if they lose that seat, then they allow the Democrats to get closer to that super majority or that quorum proof number. And then we've had a huge departure of some of our longtime, more moderate Democrats and Republicans that have really opened up an opportunity for others to come in and potentially either shift the ballot to the Republican side or to a more Democratic party. So these emerging issues will all be impacted by what happens in Salem and in DC. We anticipate that we will see quite a few issues in the 2020 session come back from the 2020 session that were just not addressed because of the walkout. But if we look at some of the other issues going into session, we could see a few of them addressed first in our third special session, which is likely again to happen after the elections and before Thanksgiving, with the focus on wildfires response and the housing issue during COVID. We as an association, along with our partners at the Oregon Medical Association, would love to see medical liability protections put forth in a third special session. Right now, many of our providers are at risk because of some of the decisions that the governor put out there, right decisions around limiting certain procedures during our first spike of COVID. But because of that, many of our patients weren't able to get the services that they needed. So We would like to have medical protections extended to them. We saw a good portion of other states do that, and we're hoping that we can either do that in this third special session, if not, maybe leading into a key priority for the 21 session. We also know that our presiding officers, so the Senate president as well as the Speaker of the House, are working to increase the participation and transparency of a legislative process. They'll probably do this as a test run in the third special session, but that is yet to be decided, and I think it might be a little too ambitious for us to think that they will open up the Capitol for the third special session, even if it is slightly modified opening up. We anticipate that the first portion of the 21 session will be done virtually. Partially virtually might be there. I think that is a wishful thinking, frankly, at this point. Just knowing that we will still be without a vaccine for COVID at that time, and we will be at the end of the flu season. I hope to be wrong, but I think our numbers are still going to be fairly high, and going into a partial virtual might be difficult. But it is important for legislators that we try to get back to normal process as quickly as we can. We have heard that the Senate President and the Speaker of the House really want to normalize the 21 session, even if it is virtually, by maintaining certain dates and deadlines that they have already passed and put into their chamber rules. So we'll follow those. The challenge they're going to have is, how do you engage the public to provide their input, and how do you engage that dialogue that happens on a daily basis in a more face-to-face meeting or even floor session that is critical to the creation of many of the bills that end up being passed. We've asked our presiding officers if they are going to limit the number of bills. They are not. So legislators have kind of that open pen to write and draft and request drafts of as many bills as they so choose. Many of the rank and file believe that that is not appropriate, and that should be limited to a very specific number, 3, 5, maybe at most per legislator, and then additional kind of number setting for the committees. This is similar to how they run the short sessions, but in long sessions, they tend to give them an open checkbook of how many bills they can be introduced. The Speaker did tell us in a meeting that we had with her that she's really going to rely on her committee chairs to really focus and kind of narrow down their bills that they hear during a committee, because committees will need to be, if we're virtual, will need to be online, and the hearings will need to be a little bit more condensed in time. So that's where they're going to look at how they can condense the number of bills that are heard versus the actual limitation of the bill numbers. Now, the themes that we anticipate seeing, kind of the overarching themes for the whole session, is really going to be budget driven. We know that Measure 108, and I hope you all vote for Measure 108, is a first step in really addressing the health authorities and the Medicaid budget gap that is coming. It won't be enough, and we know that the gap will still be there within the Medicaid program, but it does help definitely shrink that gap. And the reason why it won't completely fill it is two factors. One, we have seen about a 10% increase in the Oregon Health Plan since COVID hit, and our economy has gone down. But the other factor is we're in a type of recession, and usually tobacco users reduce or stop using tobacco, which is a very good thing. But the number of tobacco funds that have come in under the existing tax and what would be applied to the when Measure 108 passes has definitely reduced. So there is a gap there that would still need to be funded. How that will be funded is yet to be determined. I anticipate that the governor's recently appointed Racial Justice Council will have its fingers in that conversation as well. This group is a group of multidisciplinary individuals from across many different spectrums, really focused in on how we can break down the inequities and disparities across the various institutional pieces of our budget, but also of our policy, such as criminal justice, healthcare, and education are ones that I know they're going to be focusing on. So they will be part of these conversations and how we address that. I also anticipate that every piece of policy that comes across will be viewed through a lens of how is this going to improve equity and remove disparities in our state. And then the other main theme that the legislature will take up is COVID-19 and the wildfires, how we responded as a state. Are there any lessons learned that we should be taking forward? And then what does our recovery look like? How do we help move Oregon forward to that recovery state? The healthcare committee issues that we've seen and anticipate being kind of their biggest bucket of work, Rebecca will talk about here shortly, Senate Bill 889, but we know that work group continues to meet. They will likely have a product that will need to have some legislation around it to implement it. We have heard from various sources that both primary care, access to primary care, universal care, and public option are of top of interest for individuals to have that discussion. How do we modernize public health? This is a little bit in response to COVID-19, but also picking up the couple of works that we've done the last couple of sessions to really modernize public health. How do we control and contain prescription drug costs? There are many proposals out there on that. Balanced billing. This one is an expansion of the current balanced billing bill or law that's in place. One, the sunset of the kind of the mechanism that is used, the method that is used to determine the out-of-network rate expires at the end of 21. So we need to look at that. But also it expands the application of the bill to include emergency out-of-network and non-emergency out-of-network for facilities. So hospitals would have to start limiting their billing to what is limiting their billing under this proposal. So we're working on that. We're in part of conversations with the agency that is proposing this, but also with many of the proponents and opponents and how to make that work. And then equity in healthcare, we've talked about this in the previous slide, but where we anticipate the healthcare committees to really focus in on is how can we reduce language barriers when it comes to the healthcare setting, and how do we improve and increase the retention and recruiting of provider diversity in this state. So we also know that there have been some changes to rules that have really been helpful to many of our providers and patients during COVID. And so there'll be conversations about how do we capture that, make permanent changes, especially around telehealth. We have heard from our members that telehealth has been a huge has seen very much positive reinforcement by patients. They really like that. And so we will look at how we can increase that parity and access to telehealth across the state. Nurse staffing, we anticipate that there will be some changes to the nurse staffing law, especially in how a committee meets during a public health crisis. The vaccine laws, this is one where the association has been pretty out front in and encouraging, and would love to see a mandate on vaccines for folks not just related to COVID, but beyond that. And then how does the state be better prepared for an emergency? So there is conversation around PPE stockpiles. How does the state become a better purchaser on that? And then the model that we currently have, is that the right model for emergency preparedness? I think that will be in question and conversations around there too. Medical liability, the whole medical community will continue to push for medical liability as it relates to COVID. And then the health authorities agenda, they're really going to be, the top of their agenda is really putting more emphasis in their 10-year strategic plan focus on health equity. So they will be coming from every policy with this angle leading that charge. And so we'll be part of those conversations. We look forward to those conversations and in really understanding how they are going to achieve this goal. And then behavioral health, we continue to, invest and then de-invest in our behavioral health programs. So I think there will be some really strong and broad conversations around how do we continue to invest in our workforce. So looking at the workforce versus the actual programs and services, and how can we ensure that patients are getting the right access to care at the right time. So that's that simplifying access. So making sure that regardless of where the patient is, or regardless where the individual is, they can figure out how to enter into the behavioral health system. The Medicaid budget, we talked a little bit about already. This is one where we have seen the health plan numbers have increased 10% because of the effects of COVID. That really was because of the decline of employment. And then we continue to see, and we will likely continue to see this grow over the next several months. And so that is one that we continue to watch very carefully. Rebecca will talk about Senate Bill 889 and the healthcare growth target, but that is a focus point for the health authority. They will be the oversight agency for that program as it continues to be developed. And then we'll also have conversation around lessons learned in COVID. And I would almost say this is going to be lessons learned COVID plus the wildlife fires, because what we saw during COVID was that there was it really highlighted some of the inequities in our state and in the healthcare system, but also we saw where our financial system around payment for services, frankly, it was hurt during certain aspects of the COVID-19 when we had executive orders that limited our ability to perform elective and non-urgent procedures. So is there a way to help protect hospitals as a safety net during in a future pandemic? But also, how do we respond as a state and as a healthcare system for future and also dueling emergencies? So, when we were going in a pretty good rhythm with COVID through the summer, and we were, I think, really understanding what it means to be operating in COVID. And then the wildfires hit. And there seemed to be a disconnect between the public health role during COVID and the fires, the hospital role during that time, and then the state's emergency response role during that time. So really understanding those lanes as we go forward is going to be critical. So I will pause here, and if there are questions, I'm happy to answer them. If not, I can turn this over to Rebecca for the outcomes of politics, the policy side. All right. Well, I'm not seeing any questions in the question box, so I will stop sharing my slide and turn it over to you, Rebecca.
Great, thank you, Andy. Let me try to get this queued up here. Are you folks able to see my screen? Yes, okay, excellent. All right, well, as Andy said, I'm going to be talking about two different policies that were passed in recent sessions that are really coming up on implementation starting in 2021 that will have sort of broad impacts not only for hospitals but for the healthcare industry as a whole. So the first one I'm going to talk about is the Healthcare Cost Growth Target Program. This was coming out of Senate Bill 889, which was passed during the 2019 legislative session, which was actually the result of a task force which met in a previous session, which was Senate Bill 419. Really, the intention of this program is to really be multi-payer and multi-provider. There have been previous attempts around containing and controlling healthcare costs that were really focused on specific sectors. There's been policy concepts floated around hospital rate setting commissions and other specific sector target programs, and the recognition was that if you sort of squeeze the balloon on one end, costs will sort of pop out in the other. And so the intention and policy goal around Senate Bill 889 is to really have multi-payer, multi-provider, all under one common goal, one common target, and we'll talk a little bit about what that is, and really relying on transparency and public reporting and public process as sort of the mechanism for getting everybody aligned around controlling healthcare costs together with a total cost of care approach. So not necessarily focused just on hospitals, not focused just on specialists or pharmacy, but really giving folks a goal, giving a target, and then seeing what people can do to achieve that target. And so where this policy is being developed, so Senate Bill 889 created an implementation committee that has been meeting actually since November of 2019. So they've been meeting for over a year now. They took a pause during COVID-19. So they took a several-month pause in the spring and early summer and restarted their efforts sort of late summer. So that's pushed them back a little bit, and it's feeling a little rushed, but they are continuing to meet, and they have 2 more meetings through the end of this calendar year. But I'll go through some of the decisions that they've made so far and the decisions that they have sort of yet to make going into next year. But this is sort of the first thing that they landed on, sort of what is the healthcare cost growth target? It may not be a surprise to you that they landed on 3.4% for some reason. That's just where things land in Oregon. But they looked at a lot of different factors. They looked at historical gross domestic product, historical median wage, and they really landed on the first 5 years of this would be a 3.4% growth target. There would be sort of a check-in point, TBD, about what that check-in point will look like in 2025. Some type of advisory committee or body would come together to see how things are going, see where things are going with wages and gross domestic product in the economy. But the intention would be that the 5 years after that, so 2026 through 2030, the target would go down to 3%. And so that helps sort of phase things down a little bit. And so that's what where they landed. That is the recommendation of the implementation committee. So where does that 3.4% target apply? So these are the different levels of which it will be measured. And so one is just the statewide target, total cost of care, did the state as a whole meet the 3.4%? Below that is what they're calling for the market level. And so this is looking at Medicare, Medicaid, and commercial on their own and seeing if at the market level, if the 3.4% was met. And this would be the state that analyzes this using a variety of methods, but mostly looking at the all payers, all claims database as one of the main points of source for data. Below that is really at the insurer level. And so you'll see underneath the three sort of markets, how they're defining and looking at insurer level. And then below that is at the provider level. And we'll talk a little bit about what the provider level means. So this is the criteria for reporting by payer and provider performance. And so the implementation committee is still working on some of these definitions, still trying to understand what the difference is between sort of being in the reporting program and reporting your total medical expenditures, but then also being accountable. There's sort of this recognition of size that you may need to be a specific size in order to be able to be accountable to this 3.4%. And so as you can see here, when you break down that provider level, so the difference between this slide where we're looking at the bottom and this slide is really then what are the providers that are in that level. So health systems, hospitals, medical groups, IPAs, ACOs. And so anyone in the green right now is proposed to be accountable to the 3.4% at some level. So being in the public reports, you'll see the blue right now is not accountable. I think we have some questions around, pharmacy in particular, not necessarily being accountable. We know that that's a leading cost driver, and we continue to talk about that and bring that up in public meetings. And you'll see there underneath hospitals and medical groups, there's a reference to primary care providers and some level, needing some level of attribution or volume around primary care providers in order to make things measurable. So we continue to have questions about this, and we'll learn more as the implementation committee makes their final recommendations, not only on sort of the pharmacy being in blue, but also post-acute providers, as well as sort of the freestanding ancillary providers. So, and again, these slides that have the health authority logo on them are from public meetings, and I can point you to, or we can provide a link to where all of the slides have been from the implementation committee, so you can sort of dig deeper if you're interested. This gets a little bit to the beginning of their conversations around criteria for who would be accountable. So providers who meet the criteria for data submission, only payers and TPAs that submit data would be in this program. I think where we're sort of trying to understand more is that third line right there around entities with at least 10,000 unique lives or 5,000 unique lives that live under one line of business. So, we still don't necessarily have a sense of who falls into that, especially thinking about at a hospital level. But 5,000 lives could under one line of business could eliminate or not. I think the health authority needs to do some work to talk about who would be excluded and who would be included in this. And so there's some work that they need to do around that. We're going to talk on the next slide about how this program has been modeled after Massachusetts. And I think one thing that we're finding in comparing Oregon to Massachusetts is we have very different markets. We have some very small providers. We have a lot of local payers. And when you look at a market like Massachusetts, where it's really the big national players and pretty big health systems, Massachusetts has 4 critical access hospitals. And so just very different. A lot of their hospitals are affiliated with academic medical centers. And so I think going through this implementation committee process is really highlighting some of the unique aspects of Oregon. And so the program is needing to be tailored to that. So speaking of Massachusetts, one thing that we're going to see in this upcoming legislative session is around enforcement. So Senate Bill 889 gives the health authority the statutory ability to do data collection and public reporting, but they don't have any authority right now around enforcement or any sort of mechanism for sort of requiring payers and providers to perform under the 3.4% or be accountable to it. So we anticipate a legislative concept coming from the health authority in 2021. It will be one of the important pieces of our agenda for session to respond to that. But to get a sense of what the enforcement looks like in Massachusetts, it's really a three-step protocol. So the first step is again, this public reporting. So entities who miss the benchmark are sort of flagged. They're on the naughty list. You know, if you're nice and you're naughty list for like Christmas, they're put in a public report, public hearing. You know, these entities missed the benchmark. The second part of the protocol is the Health Policy Commission. So that's HPC. That would be equivalent to, you know, the state agency that owns this. So it would be OAHHS. Conducts a deeper data review of why they missed the benchmark. So they would use their own data. They can request data from the entity. They look at pricing patterns, utilization, payer mix, population served, and any other factors that may have contributed to them missing the benchmark that may have been out of their control. And so what they've seen for those that have missed the benchmark, it's usually something out of the control. So they use the example a lot of when the hepatitis C drugs came onto the market that were hundreds of thousands of dollars per treatment. That impacted the ability of entities to meet the benchmark. So if an entity sort of fails the step 2, the data review, and there's no justifiable reason out of their control why they missed the benchmark, they would be put on what's called a performance improvement plan. A performance improvement plan is really a sort of agreement between the state agency and the entity of what they're going to be doing in the next year to get to being under the benchmark. And it really opens up their books a little bit more. It gives a little more regulatory oversight over that specific entity. But the note here in red is that to date, no entity has been put on a performance improvement plan. Massachusetts has had this program since 2012, and everybody who has missed the benchmark has then sort of passed the data review section of this. And so I think the health authority, when they're looking at what their legislative concept is going to be, is really interested in finding an enforcement tool or mechanism that sort of is in between 2 and 3. So what can they pull, or what's some sort of mechanism that they can use that isn't quite a performance improvement plan, but something that's beyond just the data review and the like, okay, you're good to go. So we're really keeping an eye out for that, because we keep hearing them sort of talk about they want some sort of additional mechanisms, but we have not yet heard what those policy concepts are. So the benchmark committee has 2 more meetings, one in November and one in December. So we'll be really tuned into those so that can inform our work going into the 21 legislative session. And my final slide on Senate Bill 889 is this sort of recent tie to value-based payment. So in the last couple of meetings that they've had, particularly after COVID-19, recognizing that the fee-for-service system sort of failed in the COVID-19 world, where when volume just totally drops, finances are really volatile. And so part of that conversation was, you know, if we're in a situation again where there's, you know, public health emergency or elective procedures are being turned on and off, that really leads to, you know, sort of blowing through any sort of benchmark, because there's that instability. And so the conversation around tied to value-based payment has come up stronger this year than we've sort of heard before. And one thing on our end from the Hospital Association is we've been hearing around, different value-based payment policy conversations in several different parts of the health authority and in the state. So with our CCOs, with CCO 2.0, PEB and OEB, and now with this cost growth target, there's a lot of primary care payment reform initiatives happening. And so we, in all of our sort of public meetings and comments, is just strive for alignment. We need these plans and policies to be headed in one direction together, and the health authority needs to really take the lead on that, because if we're going to go down sort of disparate paths towards value in these different areas with different metrics and different reporting systems, we're no better off than we are today in a fee-for-service environment with all these different metrics. And so we will continue to strive for that and push for that. The health authority will be convening stakeholders around a concept around sort of a voluntary compact. And so we'll be engaged in those conversations. Before we move on to community benefit, I think I'll pause here because that's a totally different topic and see if there are any questions. There might have been one in the chat. I can't quite see the chat from my angle. So are there any questions? Question was, I was showing the wrong thing. There we go. Does that screen look better?
Perfect.
Yes? Okay. Thank you. Okay. Well, now you got to see my notes, which is great. All right. Let's move on to community benefit. Okay, thanks for the screen adjustment. I know that's always hard to see where we're at. So community benefit, this bill, House Bill 3076, was passed during the 2019 legislative session. And it was a pretty broad bill that changed quite a bit around not only community benefit in Oregon, but also financial assistance. The sort of bullets here are what the whole bill was about. And I think I actually came last year to the Benson Hotel, and we had a presentation around the financial assistance policy requirements and the debt collection practices and provisions that all went into effect at the beginning of this year. And so today we're going to talk specifically about the community benefit spending floor requirements of it, as well as the clinic and facility reporting. So if you have the bill, if you have it handy on your desk, it's sections 6 and 7, and we'll talk about what those are. So section 6 of House Bill 3076 is around this concept of a community benefit spending floor program. This was the result of several different sessions around some stakeholder communities wanting to bring more transparency around hospital community benefit, demonstrated charitable purpose for nonprofit status, really coming from a couple different angles. One is around sort of the county tax assessors, and the other is around people that represent organizations from consumers' perspectives, as well as unions. And so after a couple different sessions, House Bill 3076 is sort of where we were at negotiated in terms of a program. And so what is in statute is that every 2 years, the health authority will set a community benefit spending floor for hospitals and clinics. The health authority must consult with hospitals and provide an opportunity to respond to that floor. So we'll talk a little bit about what that process looks like. And then there must be options for reporting depending on how you're arranged with your clinics. Section 7, this is sort of the response to the advocacy efforts around the tax assessors, is around an annual report. So this is separate from the spending floor, where you'll submit to the health authority the address of each affiliated healthcare facility and clinic, whether your hospital's financial assistance policy applies, and the nonprofit status of those affiliated facilities and clinics. And I'll just note that we're still in the process of rulemaking for section 6 and 7. So we don't have, we are close, but we don't have the final documents on what this program will look like. There's still a public comment period that's open around this, and so things could change, things could be tweaked, but we should have that soon, and we'll talk a little bit about that next. But in terms of the spending floor program, it allows hospitals to sort of choose the grouping of which you want to be entering the program with. So you could go into the program as just your hospital, hospital with your clinics, a hospital plus a group of clinics. The definition of health system in here is really looking at how clinics are under common control or ownership of a hospital. And so in the current draft of the rules, there's these listed scenarios as well as some additional scenarios that are listed. And so when the sort of final rules are written, hospitals and health systems will have the choice to choose how they want to enter the program. And you have to make that choice, and you do that for the 2 years, and then you can change it. But that's what's sort of unique about this. A spending floor program is community benefit historically and traditionally has been really just at that hospital level, specifically for responding to the IRS for nonprofit status. And so this really brings that view of what are we doing as a system and at the community level for community benefit? And if your clinics are contributing to community benefit in any way or are counted in your community benefit in any way, then they're a part of the spending floor program. And so going into what the actual methodology is, I'm going to show you the principles and then the actual formula here, but I'm not going to go into all the detail of it. But these are the principles that the Health Authority and the Rules Advisory Committee sort of went into the development of this. And so, comprehensive, all 10 community benefit categories on Oregon statute, including charity care and Medicaid, are included in this. And so we are really looking at community benefit as a whole. The spending floor amount is prospective, so you will know what your dollar amount is going into the start of the fiscal year that you'll start to have to measure for this. You will know what that is. It's not this sort of retrospective look back and did you meet something or not. You will have an actual dollar amount assigned to you at the beginning of your fiscal year, and you will have 2 years to spend up to that amount. We're using and building upon existing reporting systems. So if you're familiar with your teams that implement this community benefit, it's the CBR1 and the FR3, that's your community benefit reports and your audited financial reports. We anticipate that there will be some changes to those forms. We really pushed for that to not happen necessarily during the rulemaking process, but we anticipate that the Health Authority will convene a sort of smaller stakeholder group of technical experts and those that actually do these reports to make some changes to them, but no new reporting will be required for the spending floor program. And then the other principle is that it's really objective and transparent, and what's meant by that is that hospitals should be able to calculate the formula on their own. It's not something that OHA does in a black box and spits out a number. So if you're using this formula, you should be able to get the same exact number that the Health Authority comes up using the formula, and all of the data fields have common definitions. And so that's something that we're pleased to see with. So again, those of you that are involved in the rulemaking and have been working with on this should have this formula and should have been able to sort of run it and check your numbers. How this is going to happen in the rule process is this methodology is actually an appendix to the formal administrative rule. So the actual formula is not going to be in rule, which is good because it gives the opportunity for sort of changes or tweaks that may need to happen without opening up a formal rulemaking process. But you'll see here, it's really looking at, across several years. So you're doing sort of a look back, 3-year average of your unreimbursed care plus your direct spending. And so there's a definition of what direct spending is, sort of everything else that's not charity care and unreimbursed care. Times there's a multiplier that looks at your operating margin, and that really sort of spits out a number. And then your year 2 is looking at the same number that you had in year 1 times your 4-year average change in net patient revenue. And one thing that we got clarity on was that year 2, it's like year 1 and year 2, and we're done, and then everything will reset again for the next year 1 and year 2. So you're never going to see that times average change in net patient revenue over and over and over and go up. So it's a 2-year standalone, and then we reset everything the next 2 years. In terms of modeling and what this has sort of shaped out, OHA and we, the association, took the formula and ran it using past data. So again, it's not the number that you're going to get in the beginning of 2021, but it's just a model. And we found that 13 hospitals did not meet what would have been their floor, and it ranged from $143,000 all the way up to $15 million missing it. Our assessment in talking with folks is, 4 of those would have likely met the spending floor if they went in at the system level, which is what the opportunity was that I talked about at the beginning, where you can go in with your clinics, you can go in with all your hospitals together. We know that big systems sometimes put emphasis on spending in certain communities that have certain community needs, and that may look like one hospital has less community benefit spending and another has a ton of community benefit spending, and then that sort of gets equalized out over your multi-hospital system. And so that would be helpful in this case here. And then in talking, one-on-one with some of the hospitals that did miss this, many have identified historical underreporting. And that has sort of messed up the model, like just totally missing categories of reporting some years, or there may have been a change in one of the years of who was doing your reporting. And so there's some inaccuracies and some underreporting. And there's an opportunity when we go through this process to be able to adjust and change and make sure that you're accurately reporting and you're using best practices to capture everything that you can. And so I think everyone who's in that situation that I've talked to has contacted the health authority and has talked with them about that. And so at this point, everyone who has missed in the model, the floor, has had the opportunity to talk with us and talk with the health authority. And so I think everybody is pretty ready to go for next year in terms of strategies for capturing reporting. And this is my last slide. Just next steps, like I said, the rules will be finalized in the coming weeks. The program begins January 1, but it's based off of your fiscal year. So if your fiscal year ends in the end of 2021, this program doesn't start for you for quite a while. If your fiscal year, there's a few hospitals that have a fiscal year that's in March, you're going to be starting this program pretty quickly here. And so with that, I will open it up for questions. I saw something blinking, so I'm assuming there's a question somewhere, or maybe I'm talking too fast. Let's see if I can pull that up. Okay. For multi-state health plans, is OHA considering total spend? So for the community benefit program and the 889, it's specific to Oregon. So if you have a health system and you have 2 hospitals in Washington, the community benefit spend for those hospitals and clinics does not count. Or if you're in Alaska or California or whatever, so it's just your Oregon facilities and dollars that were spent in Oregon. And same goes for Senate Bill 889, the 3.4%. Accountability lies with just people, when we're talking about those that are attributed, people in Oregon. So hopefully that answers your question. Let's see. I will stop sharing my screen. Are there any questions for me and Andy together, or broadly, or anything else we can help you with this morning?
Looks like there was some questions in there for a multi-state health plans. Did we grab that, chat?
Yep, I just answered that one.
Well, great session, you guys. Thank you very much. Very informative. Lots of information to take in. Definitely appreciate you guys joining us today. So thank you very much for that presentation. For everybody else, thank you for attending our first session. Please make sure you click on the survey link in the chat box to take our surveys. It's always great to have your feedback. A special thank you again to KeyBank for sponsoring this event. Appreciate your ongoing support. Thank you.